Today, I have been asked to talk about the medical treatment of Cushing's. Are we advancing forward or are we going in circles? Uh, at the beginning, I would like to present a case to take you through the difficulties in the management of patients with Cushing's, and then I'll go over to the main topic. So this was a 61-year-old lady who was admitted with us in the middle of March this year with progressive weight gain, hirsutism, proximal muscle weakness, new onset diabetes, hypertension, and severe hypokalemia. On examination, she was hypertensive and had the classical Cushingoid appearance with round faces and prominent dorsocervical supraclavicular pad of fat, thin skin, easy bruising, and severe proximal muscle weakness. Her investigations revealed a normal renal functions. Her alkaline phosphatase was elevated. She had hypokalemic alkalosis. Her vitamin D was low and her HbA1c was high. She did not have osteoporosis despite being menopausal for 10 years. Investigation of the cortisol axis revealed that she had very high levels of serum cortisol, both in the morning as well as midnight. It was not suppressed following dexamethasone suppression, 1 milligram, and with the 8 milligram dexa suppression, her serum cortisol suppressed by 63% and her urinary cortisol by 87%. Her basal urine cortisol was more than 100 times the upper limit of normal. With this diagnosis, clinical and biochemical diagnosis of ACTH-dependent Cushing syndrome, we proceeded with imaging. An MRI pituitary with gadolinium contrast did not show any lesion. And similarly, a gallium dotatate PET scan only revealed bilateral adrenal hyperplasia, but did not reveal any ACTH secreting SSTR positive tumors. So we were left with the diagnosis of ACTH dependent Cushing syndrome with the source of ACTH not being localized. And with the clinical and biochemical profile, it seemed like an ectopic ACTH dependent Cushing syndrome because of the very high levels of cortisol and ACTH. So because of severe Cushing's and non-localization of the ACTH source, we considered bilateral adrenalectomy, but she was a very weak and fragile patient who had severe hypokalemia and severe muscle weakness. Hence, she needed prior medical control of her hypercortisolism. And by the time we could do this, we were in the middle of the second wave of the COVID pandemic. So initially, she was started on Ketoconazole 200 milligrams twice daily, which was progressively increased over time because of persistently elevated urinary cortisol. And when she was at the dose of 800 milligram per day, her liver enzymes went up to more than 3 times the upper limit of normal, indicating intolerance and necessitated stopping ketoconazole. For the treatment of diabetes and hypertension, she required maximum medications, and her hypokalemia was very refractory, needing about 40 to 50 grams of IV potassium infusion every day. So, because of the intolerance to ketoconazole, we considered initiating Mitotane therapy for her because we needed some therapy to suppress the cortisol over longer periods of time because of the COVID pandemic. So when we procured Mitotane, and by the time her urinary cortisol was 200 times the upper limit of normal, the Mitotane was started at 250 milligram twice daily and progressively increased dose over the next 2 to 3 weeks to a dose of 1 gram twice daily. And with that, we were able to get down her urinary cortisol to about 8.5 times the upper limit of normal. Her diabetes, hypertension were controlled, and she was off the IV potassium supplementation. During this time, she had multiple episodes of septicemia with multiple organisms, including the rare organism Stenotrophomonas maltophilia, which occurs in immunocompromised patients. And all of them were successfully managed with IV antibiotic therapy. And lastly, she was discharged after 60 days of hospital stay and advised to come back after the pandemic is controlled for bilateral adrenalectomy. So from this case and from our understanding of Cushing's over a period of time, we know that Cushing's affects multiple organs and metabolic systems, causing diabetes, severe hypertension, hypokalemia, increased risk of thromboembolic and cardiovascular events, risk of infections, neuropsychiatric, musculoskeletal, and reproductive disorders. And hence, there is a need to immediately control all these problems, which can be detrimental. Among the various causes of Cushing's, including ACTH dependent as well as ACTH independent Cushing syndrome, the primary treatment of all these conditions is surgical resection of the primary tumor, be it an ACTH secreting tumor or an adrenal tumor. But when the source of ACTH is not localized or the primary treatment fails, then bilateral adrenalectomy would have to be resorted to. So transsphenoidal surgery has been reported to have very good outcomes over the recent years, and the remission rates of microadenomas range from about 85 to 86%, and that of macroadenomas 60 to 75%. With regard to radiotherapy, which is usually used in patients with persistent ACTH secreting tumor or in those who have recurrence, conventional radiotherapy has an efficacy of 55 to 65%, while stereotactic radiotherapy or radiosurgery have even better efficacy of 92 to 96%. But there are these problems of long-term hypopituitarism, increased risk of cerebrovascular disease, and secondary brain tumors as well. Bilateral adrenalectomy would be resorted to as an elective procedure in those who fail primary treatment or as an emergency in patients with life-threatening complications like the case described just now. And in such kind of emergency bilateral adrenalectomy, the patients have to be prepared with 1 to 2 weeks of medical treatment, either with etomidate infusion or multiple medications in order to rapidly control the cortisol excess to reduce the perioperative morbidity and mortality. The most common complications which we would anticipate would be adrenal crisis, which occurs in about 4.1 to 9.1 patient per 100 patient years, which is similar to primary adrenal insufficiency, and Nelson syndrome, which is described in about 20% of patients. The surgical morbidity per se is about 15%, and the mortality is 3%. And hence, it can be resorted to as a procedure of choice in patients with life-threatening Cushing's. Now coming to medical therapy, we have medical treatments available which target the pituitary, where we have primarily the dopamine agonists and the somatostatin analogs. There are also other drugs which have been recently used but in smaller numbers. Among the adrenally directed therapies, we have various drugs ranging from Ketoconazole, Levoketoconazole, Metyrapone, Mitotane, Osilodrostat, and the glucocorticoid receptor antagonist which has been used is Mifepristone. So what are the indications of medical treatment for Cushing's? Medical treatment is indicated in a patient getting prepared for surgery, especially in those with very high cortisol levels, to normalize the cortisol to reduce the perioperative morbidity and mortality. When the source of ACTH secretion is not localized, after unsuccessful pituitary or ectopic ACTH tumor surgery, to reduce the morbidity in patients with inoperable or metastatic adrenocortical carcinoma, as a bridging treatment while waiting for pituitary radiotherapy, while it is still yet to be effective, and in patients with severe life-threatening psychiatric complications, or when surgery is delayed due to the COVID-19 pandemic. Now coming to pituitary-directed therapies, cabergoline has been studied in 20 patients with Cushing's, not in remission following surgery, initiated at 1 milligram per week and progressively increased to achieve normalization of urinary cortisol or to a maximum dose of 7 milligram per week. Its short-term efficacy was about 75%, and at the end of 2 years, the long-term efficacy of controlling urinary cortisol excretion was about 40%, and tumor shrinkage in 20%. Looking at various studies which have looked at the response to cabergoline therapy, the long-term remission rates range from 23 to 40%, and treatment escape has been described in about 33% of patients. In an elegant meta-analysis from JIPMA, where they included 124 patients with Cushing's disease, remission with cabergoline therapy was noted in 39% of patients, and 22% of patients escaped from remission during long-term therapy. An important point to note with regard to the use of cabergoline in patients who undergo radiotherapy comes from this study from KEM, where 42 of their patients who had radiotherapy for Cushing's disease, about 69% of patients achieved remission and 21% had recurrence. And recurrence was exclusively seen among patients who received cabergoline therapy around the time of radiotherapy, ranging from 6 months before radiotherapy to 6 years following radiation treatment. And hence, it's important not to use cabergoline around the time of radiotherapy for ACTH secreting pituitary tumors. ACTH secreting tumors express SSTR5, and pasireotide is a drug that targets that. So, this is a double blind multicenter study in 162 patients, which studied two different dosage regimens of pasireotide subcutaneous daily, 600 microgram twice daily versus 900 microgram twice daily. And at the end of 12 months of treatment, 13% of patients on the lower dose and 25% of those on the higher dose achieved normalization of urinary cortisol levels. And when we look at the patients, subgroup of patients, we find that patients who had mild to moderate hypercortisolemia, that is, those with urinary cortisol excretion less than 5 times the upper limit of normal at baseline, were more likely to achieve remission compared to those who had higher cortisol levels at baseline. So, pasireotide subcutaneous normalized the urinary cortisol levels in 68% of patients with mild to moderate Cushing's, and the long-acting preparation also had a similar efficacy of about 46%. Now, coming to adrenal-directed therapies, we have various drugs in this class, of which ketoconazole, mitotane, and etomidate inhibit the proximal enzyme, that is the side chain cleavage enzyme. Ketoconazole also inhibits 17-hydroxylase, and all of them inhibit 11-beta-hydroxylase and aldosterone synthase. Looking at the data on ketoconazole, ketoconazole inhibits the side chain cleavage enzyme 17-alpha-hydroxylase and 11-beta-hydroxylase. This was a French retrospective study from 14 centers in 200 patients, where they found that ketoconazole treatment normalized the urinary cortisol in about 50% of patients. About 25% had partial control, and a large proportion of their patients had improvement in their comorbidities of hypertension, hypokalemia, and diabetes. But about 15% escaped after the initial control. And the major adverse events were elevated liver enzymes, which was seen in about 16%, and GI complaints in 13%. Levoketoconazole is a 2S4R enantiomer of ketoconazole, and it's a more potent inhibitor of the cortisol secreting pathway enzymes. Its efficacy has been studied in the SONIC study, where 94 patients with endogenous Cushing's were enrolled, and levoketoconazole treatment was given for a period of 6 months. And here the cortisol estimations were done by the LCMS cortisol assays. So among these patients, 31% of their patients normalized their urinary cortisol levels by 6 months. The adverse effects were mainly about nausea and headache in about 1/3 of the patients. Severe adverse effects occurred in about 13%, requiring discontinuation of treatment, and they were QTC prolongation, adrenal insufficiency, and elevated liver enzymes. Because of the inhibition of 11-hydroxylase, there is increase in 11-deoxycortisol, which has a significant interference with the cortisol immunoassays, and hence, while assessing response to levoketoconazole, it is recommended to measure cortisol by LCMS rather than an immunoassay. Osilodrostat is another inhibitor of 11-beta-hydroxylase, and its efficacy has been studied in the LINK-3 study, where they recruited patients with endogenous Cushing's and started them on Osilodrostat 2 milligram twice daily, which was progressively up-titrated, and a maintenance dose was maintained for 12 weeks. And subsequently, patients who had previously received radiotherapy had a randomized withdrawal to see whether the effect seen was the effect of radiation therapy or was it the effect of Osilodrostat. So there were 137 patients in this study, and at week 24, 53% had normalized their cortisol. And at week 34, after randomized withdrawal, 86% of patients on Osilodrostat remained in remission, while only 30% of those on placebo, indicating that the remaining had persistent cortisol excess which needed medical treatment. Adverse effects were mainly nausea, headache, and fatigue. Again, increased 11-deoxycortisol interferes with the immunoassay. Metyrapone, again, is an inhibitor of 11-beta hydroxylase. Its efficacy is studied in a retrospective multicenter study from UK involving 164 patients. So the response was assessed by cortisol day curve, where about 4 to 8 measurements of cortisol are taken through the day, and the average less than 10.9 microgram per deciliter is taken as normal. This was achieved in 55% of patients on metyrapone and normalization of UFC in 43%. In those who received at least 6 months of metyrapone therapy, 72% normalized by the cortisol day curve and 64% by the normalization of UFC. It is the only drug that is safe in pregnancy. Adverse effects were mainly GI upset, and most of them occurred within 15 days of initiation of treatment. Though from the pathway it works, we would expect more severe hypokalemia. Hypokalemia was not a significant adverse effect with metyrapone. Now coming to Mitotane, which is a potent inhibitor of multiple enzymes along the cortisol synthetic pathway. Its efficacy has been studied in patients with adrenocortical carcinoma, and it has been shown to improve recurrence-free survival after surgery, and especially when it is combined with RT. Various guidelines recommend using Mitotane as an adjuvant therapy after surgery in those with residual tumors or those at high risk of recurrence. It is started at a dose of 1 to 1.5 grams per day and progressively titrated by monitoring trough Mitotane levels every 2 weekly initially and subsequently monthly to achieve a target level of 8.5 to 20 milligrams per liter. It is associated with various hepatic, neurologic, and blood-related adverse effects, and it is a hepatic cytochrome enzyme inducer, and hence it can affect the metabolism of other drugs, and drug interactions have to be kept in mind. While treating adrenal insufficiency due to Mitotane, which is a common problem with this drug, we have to use double the dose of hydrocortisone because it gets metabolized quickly. While monitoring efficacy of Mitotane treatment, salivary cortisol is preferred because serum cortisol is increased as well as the urinary clearance of cortisol is increased by the drug. Next, coming to etomidate. Etomidate is used as a last resort in patients with severe hypercortisolism before taking them up for adrenalectomy. It inhibits 7 side chain cleavage enzyme and 11 beta hydroxylase. It has a short half-life and it acts very quickly. It is given as an IV infusion, preferably in a monitored setting like an ICU, with measurement of cortisol levels every 6 hourly and the dose adjusted accordingly. It causes rapid lowering of cortisol within 12 to 24 hours. And in patients at high risk of hypocortisolism, you may have to give a concomitant replacement of IV hydrocortisone infusion. Mifepristone is a glucocorticoid and progesterone receptor antagonist whose efficacy has been studied in the seismic prospective study in 50 patients. Because it is a glucocorticoid receptor antagonist, here we cannot use cortisol or ACTH measurements to assess efficacy of treatment, and so efficacy is assessed by improvement in the metabolic parameters and the body composition. About 60% of these patients had better glycemic control and 40% had better control of their blood pressure, along with improvement in depression and quality of life. Adverse effects, hypokalemia is a significant adverse effect in this patient, and also because it's a progesterone receptor antagonist, it can cause endometrial thickening and abnormal bleeding. It is an inhibitor of hepatic cytochrome enzymes and can cause various drug interactions, QTc prolongation, and when a patient develops hypocortisolemia due to mifepristone, it has to be treated with a potent steroid like dexamethasone in order to overcome the inhibitory effect of mifepristone on the glucocorticoid receptor. In addition, of late, combination therapies have been studied. This is a study looking at ketoconazole or cabergoline monotherapy alone, and in those who fail monotherapy, addition of the second drug. So what was noted in this study is that the combination of ketoconazole and cabergoline led to normalization of the urinary cortisol in 79% of patients and late night salivary cortisol in 29% of patients. There was no difference among patients who were initially treated with cabergoline or ketoconazole. Either ways, the patients responded. Sequential combination therapy with pasireotide, cabergoline, and ketoconazole has also been studied, and this improved and controlled Cushing's disease in 88% of patients. Similarly, combination adrenal-directed therapy with ketoconazole, Mitotane, and Metyrapone has been tried, and it led to normalization of cortisol in 64% of patients with significant adverse effects. In a meta-analysis of various medical therapies for Cushing's disease among 1,000 patients, Metyrapone and Mitotane were the most efficacious drugs with 82% and 60% efficacy respectively, much higher than the other drugs. And when it comes to side effects, severe side effects were more with Mitotane and ketoconazole. Coming to some of the practical considerations in medical therapy, we have to note that Metyrapone is rapid onset in action, while Mitotane is slow. It requires about 2 to 3 weeks to normalize the cortisol levels. Mitotane is a hepatic enzyme inducer, while Mifepristone is an enzyme inhibitor, and both of them have significant drug interactions. Some of these drugs cause QTc prolongation. Mifepristone is known to cause multiple drug interactions. All the 11-beta hydroxylase inhibitors increase the 11-deoxycortisol, and so there will be interference with the immunoassays, and hence we should be careful in interpreting the cortisol reports. And in patients on Mifepristone, cortisol and ACTH cannot be used for monitoring therapy. In patients with less severe Cushing's, we could use the titration regimen where we start with one drug and titrate upwards. In those with severe or cyclical Cushing's, we should use the block and replacement regimen. And while monitoring the regimen, we should check the trough pre-dose serum cortisol levels. When should we consider multiple drug therapy? We should consider multiple drugs to control cortisol excess when the urinary cortisol levels are more than 30 times the upper limit of normal, or when there are dose-dependent adverse effects. In addition, patients with Cushing syndrome are at increased risk of thromboembolism, cardiovascular disease, and infections, and these have to be managed appropriately. In this day of COVID, evaluating and treating patients with Cushing's is becoming a challenge. In those with mild or doubtful Cushing's, wait for the pandemic to settle and then evaluate them. In those with definite evidence of cortisol excess, do the baseline biochemical investigations, minimal imaging to rule out an adrenocortical carcinoma or an ectopic ACTH secreting tumor. And in those with severe cortisol excess, plan an early surgery, and in the others, surgery can be delayed while the patients are put on medical treatment. Similarly, if a patient with pituitary Cushing's has a site-threatening large tumor compressing the optic chiasm, then early surgery should be considered. We can either use the titrating regimen or the block and replacement regimen to control the cortisol levels and monitor the serum or urinary cortisol levels as feasible, and follow up these patients on teleconsultation. Several newer drugs are available in the pipeline, including retinoic acid derivatives, thiazolidinediones, heat shock protein inhibitors, cyclin-dependent kinase inhibitors, etc. These have been studied in smaller numbers, and we still need more evidence to use them in clinical practice. In summary, medical therapy has a definite role in the management of Cushing's, in preoperative control of hypercortisolism, those who failed primary surgery, with those with relapsed Cushing's disease, as a bridge therapy following radiotherapy, and those with metastatic adrenocortical cancer. Specific precautions have to be followed while monitoring the cortisol levels in patients on treatment. And we should keep in mind the drugs which cause hepatic enzyme changes, drug interactions, and QTc prolongation, and always choose the right cortisol replacement in case of adrenal insufficiency. Overall, it seems like we have made a significant progress in our understanding and management of medical treatment of Cushing, and hence it seems like we have gone ahead, and there is an advance forward, and hence medical treatment is of value in selected clinical situations. Thank you.